I am Chantal Mathieu. I'm an endocrinologist from Leuven, Belgium. And I will be your first speaker, where I will bring to you a topic that is quite dear to my heart, namely a call out to have criteria for quality of CGM sensors. Then I will introduce my friend and colleague and predecessor as president of ESD, namely Professor Stefano Del Prato from Pisa in Italy, who will talk about CGM in type 2 diabetes. And then we will have two duets, if I may call them this way. One duet between a Dutch and a Brit, namely Dr. Peter van Dijk from Isala Hospital in Zwolle, with a vast experience on pumps and automated insulin delivery, and Dr. Patrick Chowdhury from Leicester in the UK, and they will discuss AID experience, how to initiate, how to manage, both from their own clinical experience. And then there will be a second duet, and that is now with Mark Taub from Abbott. He is Vice President Technical Operations, and a clinician, Dr. Ketan Dattaria from Norwich. And Ketan will set the scene about an unmet need that we still have in the treatment of people living with diabetes, namely measuring ketones and potentially measuring ketones more frequently. And Mark will try and give an answer how we can even start to think of measuring ketones continuously and what is possible, what will be coming to us in the near future. So, as you can see, quite an exciting program with just me as a girl to keep all these boys in check. But I promise you this will happen. We hope to have time for questions. We would like to have your input. You know the drill. Go to the interactive features of the app you have been using now in the last days, or scan the QR code. Keep your questions coming. As said, I will start by bringing this topic that we need quality when we talk about glucose sensors in our hands in a clinic. Here are my disclosures. Thinking of sensors, thinking of continuous glucose monitoring. I am unfortunately old enough to remember these days when we had the first machines coming to us that allowed us to measure continuously glucose under the skin that was then translated to a blood glucose value. They were rather experimental machines, but progressively they really changed the way we do medicine. And you have to admit that in people with type 1 diabetes, but also in many, many people with type 2 diabetes, we now almost blindly rely on the data that are being put forward by these continuous glucose monitors. We have partners we've known for many, many years that have been producing sensors that we have been using in thousands, if not millions of people all around the world. But we also have new players coming in the field where it is sometimes less easy for us as practicing physicians and practicing clinicians to see what the quality of these sensors are. And I'm not saying that the new ones are worse than the old ones, but we need data to be able to evaluate as clinicians the value and the trustworthiness of these sensors. And we have seen some issues in Italy, some issues in Portugal with sensors coming on the market where there was unclarity on the quality of these sensors. And we live in a real world where it is very often our vendors in our institutions who almost decide on what technology we will be able to use as clinicians, and they twist my arm, and I need to fight and fight to say, no, it's not only the price. I also want to see the quality of the continuous glucose monitor I will be using. Don't we have a quality measure? Don't we have MARD? Indeed, we do have this MARD, mean absolute relative difference, namely an indicator that gives us a mean value, comparing the value that is put out by the glucose sensor, and on the other hand, the value that is really in the blood. And so this MARD number, we all know these numbers, mostly around 10%, these numbers can mean very different things. Here, for instance, you see a Clark grid with a MARD of around 8 and here around 12. So you would say 8 is better than 12. But look at the numbers of points you have on the left-hand side and on the right-hand side. So a number, a mean number, can be a bit misleading when you don't know where this number comes from. Second, a mean number, when you think of it, is that enough? When I give you the mean depth of a river you want to cross, you don't want the mean depth. You want the depth at every place so that you don't drown in an unexpected pit in the middle of the river. So having a mean value is probably not enough. So MARD alone may not reflect the clinical accuracy across the entire glucose range, across the whole breadth of the river you want to cross. And so it may mask significant errors in specific glucose ranges when a sensor is not capturing exactly the values at the high levels, but more worrisome when it's not capturing exactly the right values at the low levels. And also when it doesn't account for the clinical impact for errors and in specific ranges, what I said, especially in the low ranges. And we need to have sensors that we can trust, because we as clinicians adapt our insulin doses on the basis of the curves. But our patients, the people using these sensors, adapt their day-to-day insulin doses, adapt their behavior, what they will eat, what they will do, whether they will go to bed at night without having a snack. We need trustworthy sensors. And so in the US, the FDA has now criteria being put forward for evaluating the quality of sensors. They call it iCGM standards. And so what is there is that they have integrated different criteria I will be showing you that actually rely on three things. First of all, there need to be robust clinical data that demonstrate the accuracy of the device in the intended use population. Not only in adults of 70 kilos between 20 and 40 years, but also in elderly people, in obese people, in young people. There needs to be also a focus on the distribution of individual measurements than just the mean value, just the MARD. The MARD should be there, but more is needed. And then also, there needs to be an information on accuracy of the sensor across the entire glucose range. And here you can see, for instance, the iCGM criteria, where you see that you need to be in a specific range within an error of a specific number of milligrams per deciliter in so many % of the readings. And so they have many, many criteria that they put forward. And the sponsor of today's symposium, Abbott, has their sensors, the Freestyle Libre 2 and 3 systems that are ticking all of the boxes here. Robust clinical data across the population, meaning we need data of sensors being tested in people with type 1 diabetes and type 2 diabetes, in adults and in pediatrics. And I fully agree with Dr. Klonov in his review paper here, where he says, actually, we are also in desperate need of other populations. We really would like to know whether this sensor also works in pregnant women, for instance, as an example. So let me poll you. Go to the poll, scan the QR code. How many CGM manufacturers have devices that have iCGM approval? 1, 3, 5, or 8? Vote now. You have 20 seconds, but I will not sing. People coming in, I'm not having a stroke, we're waiting for the results. Okay, so 2/3 of you say that it's 3 manufacturers. 1 in 5 think that it's 5 manufacturers. Well, let me give you the right answer. It is 3. So Dexcom has devices with the iCGM label. Abbott, as I showed you before, with the Libre Freestyle 2 and 3, and also Senseonics with Eversense. So only 3 manufacturers have these devices. This is Europe. Where are we in Europe? Well, we have the Conformité Européenne, so we have the CE mark that we give to machines like your dishwasher machine and whatever you have in your house, they all have a CE mark. But for medical devices, we have often specific quality criteria, ISO standards, for instance, for pacemakers. We have also standards for pumps. We know it for glucose meters. Can you believe we do not have that for CGM? A CE mark is enough. And that is why we made a call a couple of weeks ago. We wrote an article with a group of experts where we said, actually, we should also have an European, an eCGM criterion, set of criteria, a minimal set of criteria that are backed by, where claims can be backed by robust clinical data, as said in different populations, also across the whole glucose range, and also in a dynamic glucose range, because it is important to have trustworthy sensors. And so here you can see the 7 points that we listed. Again, on top of the CE mark, there should be a performance testing of the sensor for the claims of the system. There should be consistent analytical and clinical performance, accurate real-time glucose data transmission that is guaranteed and not dropping out all the time, should be tested across a big range of glucose changes. Changes in performance under different rates of change of glucose should be reported, as also interference, for instance, with specific substances. It should be reported. There can be interference, but at least let us know. And also, there must be system design safeguards that are also put forward. And so for us clinicians, to make it clear to you what are the minimum criteria that we like to have, is we like to have these sensors tested in all kinds of populations, of whom at least 70 to 75% are people with type 1 diabetes, where you have the biggest change in glucose levels. And also, we want these sensors tested with meal challenges and with insulin challenges. And we want a minimum amount of readings of the sensor being reported in the time below range and in the time above range and very high above range level. So, this is out there. We as ESD have made a lot of noise already in press releases, etc., to really bring attention of policymakers, of clinicians, of regulators to this issue. But I think also we as practicing clinicians should also put a lot of emphasis on that. So my key takeaways, I think CGM have revolutionized the way we do our care of people living with diabetes, in particular in those using insulin. You will hear from Stefano also in other populations. Not all CGMs are created equal. In the US, FDA has very specific criteria, and experts have a consensus that also in Europe we need specific criteria to give us certainty on the safety of the tools we're using. Thank you for your attention.